Okay, so we're starting now. Good afternoon, everybody. My name is Dr. Iseko. With me is Dr. Aofisoye, and the chairman and the moderator of this occasion, we are very honored to have one of what people I call custodians of the profession with us, Professor Anuma. We're very glad to have you, man.
Thank you.
Thank you very much.
Thank you.
Thank you very much. Professor Anuma taught me as a student. And so we're very, very honored to have her with us. She's a consultant physical endocrinologist. So Dr. Aofisoye, Dr. Iseko are here from cardio care. Dr. Daffy will be joining us. Dr. Daffy is both with cardio care and the University of Port Harcourt Teaching Hospital. And we'll be going along the whole spectrum of peripheral artery disease as much as is possible. So this is from cardio care largely, but we have gladly supported this week by Medtronic as well. Please, I don't know if you have any words to say.
Good afternoon, everyone. I want to thank Cardio Care and Medtronic for inviting me to chair this program. It is always a noble thing for us healthcare providers to get empowered, to get more skills so that at the end of the day we can make better positive impact in the lives of our patients, because that's what they are looking up to us for. And so it's a good thing that Cardio Care is doing. I want to commend you for it, and I hope you will continue it. It's also exciting for me to meet with my students. Thank you. So thank you very much. I hope that we will all have an exciting time this afternoon. Thank you.
Thank you very much. So I'm glad everybody can hear. Somebody said they can hear clearly. That is great. If you have a problem hearing or logging in, please just put it in the chat box and somebody will attend to you. While we are going on, just put your questions in the Q&A, and at the time we will go on to take them one by one. Okay.
Okay. So the topic for the seminar is peripheral arterial disease. The seminar we're organizing in 2021, October, and the first speaker. Okay. So the first two speakers are Dr. Aofisoye and Dr. Iseko. So they are going to tell us about, the challenges we have with peripheral arterial disease, especially in this setting, where it's a serious problem, but when you add the multifactorial issues we have in our setting to it, it actually can make it appear more deadly than ordinarily it would have been. We mainly run an out-of-pocket system in this country, and that is really terrible for our healthcare system. Our patients are not actually able to afford the best most times because of the kind of system that we run. But let's see what we can get from here, how healthcare providers can be empowered to handle peripheral arterial disease timely, so we don't have our patients losing their limbs or dying. So I'm sure you are in for something exciting. So thank you very much.
Thank you very much. Okay, Dr. Aofisoye, so we are going straight into saving the limbs. Disclosures, the webinar is run by the Limb Hospital System. Cardio Care is one of the hospitals in the hospital system. And there's also the Limb Specialty Hospital and the Limb Children's Hospital. The whole idea of the Limb Hospital is to empower Africa through training, research, and development. And this is what we are trying to do. Yes, we're not in the university system, but we believe that we can empower ourselves here in Nigeria particularly. Right now we have over 100 participants, and this is from around the country and around the world. We have people from US, UK, Trinidad and Tobago. We get requests from China for people to come and do internship here, and that's today's webinar particularly is supported by Medtronic. For a lot of us, we don't quite know what Medtronic is. So let me give it, although they will talk about themselves later. Medtronic is one of the few international companies that is here in Nigeria supporting invasive cardiovascular work, from coronaries to peripheral to devices. There are other big companies, but Medtronic is one that has thought it wise to come to Nigeria, set up office, and give support a lot of times to training and to actual doing procedures, to empowering physicians to go with more. We are really grateful to them for also helping and supporting this webinar particularly. And so we'll go straight into. So this is what the naming hospitals look like. This is what cardio care is. Naming hospital means central area and naming children's hospital. And naming hospital tries to, and cardio care tries to reverse medical tourism. So the general advocacy goals of our seminars is typically to understand, to detect, to treat, and to prevent. So we want people to always be able to understand the condition that we're talking about, to detect correctly, and to be able to treat the disease. So we expect a vast range of healthcare professionals that are here now to be able to, at the end of the day, properly treated patients means a better Nigeria. We can complain about Nigeria all we want, but the first thing we can do is actually become more valuable. And that's what this advocacy is all about. So to officer, about this particular seminar.
Absolutely. We want our audience, the participants, to be able to overall get refreshed about peripheral arterial disease. At the end of this presentation, if we're able to screen and pick out from your clinic patients that actually have PAD that you're not even aware of before and they're not aware, I think we've done some justice. And of course, when we identify these patients that have peripheral arterial disease, we should be able to evaluate them through the thorough clinical and investigative modalities, both physiological and imaging. And of course, in the few patients that need invasive interventions, we should be able to identify them and then send them to where they can get further help. So if we're able to achieve this today, I would say that we've done something laudable and improved our skills.
Okay, great. So going straight on into it.
We'll start the case discussion. So here's the case discussion that's shown on our screen. Here we have Mr. Rufai, a 72-year-old man, hypertension and diabetes. It's a common scenario. He has been complaining of pain and numbness in his feet and one leg over the past couple of years. He described the pain to be worse at night, only minimal relief from gabapentin that was prescribed earlier. Glycemic control is good. Lastly, A1C was 6.7%. And then recently, they sustained a wound on the dorsum of his foot and then started having darkening of his last three toes. Of course, the first paragraph about the symptomatology of the patient is actually very common. Maybe up to half of patients with diabetes in some clinics, okay? But as at the time we're having him having the wound on the dorsum of the foot and some darkening, some things are probably too late at that point. Or how should the patient be evaluated?
Okay, so first looking at this case, we wonder 6.7% good glycemic control. So why? Why? Is it from the village?
Patients actually find it difficult to understand when they have diabetic complications, despite their A1C being controlled at that point in time. But it's easy to forget about the yesteryears where control could have been poor. And then people find it difficult to understand sometimes that complications can happen even despite good control.
I don't know if you...
Yeah, it's very important for people to get to know that if diabetes is diagnosed today, it doesn't mean that the whole problem started today. Now, we have a phase we call the pre-diabetes stage, and consisting of either an impaired fasting glucose blood level or an impaired glucose tolerance. Now, the danger of this phase is the fact that macrovascular complications can start in this phase while the person is not obviously diabetic yet. I have an unfortunate story. A colleague of ours, a surgeon, had a family history of diabetes, but he was never really known to be diabetic. And on this fateful day, it was the surgery day, he had 4 majors on the list. On the 4th one, he had chest pain. He thought it was acid related and asked for antacids and all that. But by the time he was finishing, he continued. By the time he was finishing that 4th surgery, severe, it became very severe, sweating and all that. He was rushed to the ICU. And in the ICU, random blood sugar was 15 millimoles. We had a massive MI, and he died that same day. So that's why we emphasize that when patients come for the first time and we diagnose diabetes today, we must take our time to look for how much of the chronic complications are present in this person. Because we know that that pre-diabetes state can be there 10 years, 15 years, without the person knowing anything is happening, but then the vessels are all damaged already. So yes, this person came with HbA1c of 6.7, but so much damage had happened in the past.
Thank you very much, man. In fact, a lot of food for thought. So, so how do we define peripheral artery disease? Maybe I will take this one. Essentially, definition encloses all the pathologic states and that leads to stenosis, and now aneurysm is also included in non-coronary and non-cerebral arterial circulation. Typically, in the aorta and the arteries of the limbs. A lot of times we exclude coronary because they have another kettle of fish, or cerebral because they form another body of their own. But this is also called peripheral vascular disease. Some people argue that venous disease should be under the same umbrella, and the peripheral vascular disease, which consists of arterial and venous disease. But several things have come on and on. I think a lot of times the limb disease has now been also further classified to lower extremity arterial disease needs. And then this also talks about the definitions. Critical limb ischemia.
Absolutely. So critical limb ischemia is the worst of the worst of the peripheral arterial disease. It's like maybe the equivalent of unstable angina or MI of the peripheral arterial disease. So we say it's critical when there's gangrenous change, there's ulceration, tissue loss, rest pain that is lasting for more than 2 weeks. So if you have someone that has any extent of measurable peripheral arterial disease, for example, and has a wound that is not healing for more than 2 weeks, we can define that as critical limb ischemia. But most of the critical limb ischemia will probably have some rest pain or some gangrenous changes. And also, when we're doing our ankle brachial index, if the absolute pressure in the foot vessels, the dorsal pedis and the posterior tibial arteries, the absolute value is less than 50 mm of mercury, is defined as critical limb ischemia as well. It's important to define critical limb ischemia and identify because the risk of limb loss of gangrene is extremely high, actually. It's often symptomatic when it's critical, and of course, many of those criteria we put up upwards there are the things we find, and we know that someone has critical limb ischemia.
Okay, so why is this? We are talking about peripheral artery disease. Some people have never even read about it, or they read about it, or just one of those chapters in school. Why will Medtronic and cardio care come today to now be talking about it? What is so significant about peripheral artery disease?
Peripheral arterial disease is a serious issue. It is common. It is common. Prevalence, some prevalence are quoted here. By the time we are getting above 60s, prevalence is greater than 10%. That's one. And of course, just like many cardiovascular disease burden, African Americans, which may or may not be juxtaposable to native Africans, they have even twice as much risk compared to their Caucasian. And also, as people are aging, we are getting this more and more. As the diabetes prevalence and hypertension prevalence is going higher, we're having it more and more. And especially is a serious marker of cardiovascular disease. Some people have argued before that if you palpate someone's posterior tibial and dorsal pedis artery and it's absent, you can define that person as peripheral arterial disease with your imaging studies. You can almost, yes, a very good likelihood that there's coronary artery disease as well, and cerebrovascular disease as well. And that's why many of these people with peripheral arterial disease, the cardiovascular burden and cardiovascular likelihood of major adverse cardiovascular events is extremely very high. So it's actually critical that we are actually able to pinpoint patients that have peripheral arterial disease.
There is some local studies. I know Prof has a lot of experience in the research, but I know there are some local studies. I know locally 20-30% of patients with hypertension, some Nigerian studies.
Yeah.
Of course, depending on how it was defined, most of the studies are always using anti-platelet index. Some African American studies talk about greater than 20% in people above 50. But here in Nigeria, you can see 1 in 5 to 1 in 3 patients in the clinics are having this. Do you think perhaps this is overlooked? Maybe we should be doing more. I don't know what. Prof, I don't know what your experience is like now.
I think that we need to pay more attention to history and physical examination in our patients. Because many times there are subtle signs that tell you that something is happening. It's just that we may not pay much attention to it or ask the patient. For example, when I teach medical students or residents, I talk about early signs of peripheral vascular disease in the limbs. If you ask you examine, just looking at the limbs can tell you there is trouble happening here. You look at the skin, you look at the hair. If the person used to be hairy in the limbs and is no longer there, or the person tells you, you see a change of color. Maybe the foot is looking darker than the rest of the limbs, or just putting your hand there. Differential want, or the person tells you, oh, I feel cold in the limbs. Little things can actually tell you, not because the tendency is for people to wait until people have intermittent claudication. Yes, that's in fact, I tell my students that the only question everybody knows about peripheral artery. Yeah, that's the only question everybody will ask. Oh, the intermittent. And once they ask that intermittent claudication, that's the end. That's the end. But there is so much to ask that if you ask the patient and the patient gives you the answer yes, you know something is happening and we need to do something about it even before it gets to the stage of the intermittent claudication or rest period. So there's so much we can do very early if only we will pay. That's why I'm very particular about clapping. And I don't like it when we trivialize clapping for our convenience, because the tendency to do that is always there. Yes. Trivialize it to our convenience. So it's shorter, but a little tiny detail from a patient can help you to save the life of that patient. And maybe just looking at the limbs, looking at the nails, the color of the nails is enough to tell you something is happening to the vessels here. So that's where I want to come from, that we need to, pay more attention to questions and examination of these patients, and that will help us to identify things very early before the patient gets to, the stage of the critical ischemia and universe.
Thank you very much, man. In fact, if we could stop here, we have tried, because now we have seen the news. Before we had all the gadgets here in cardiology, I started receiving a lot of referrals for peripheral vascular disease. I used to also think that maybe it was not very common. But by the time we started seeing all these cases coming in very late, we had to go back and start critically appraising these patients we are seeing. Are we, and how in depth are we checking for this? So if you are not checking, you will not see.
You will not see.
So I think that these numbers, 20% likely represent what is the true figure. But I remember that this is a dedicated study. I don't know that this is in every clinic. So if you ask most physicians, they'll tell you, well, I've seen 1 in my practice, 2 in my practice, but really, perhaps maybe more.
Well, for people with diabetes, of course, the commonest problem is neuropathy. Yes. Of course, people who will present with diabetic with neuropathy followed by vascular disease. So about 70% of patients who present with foot disease, they have neuropathy. Yes. But we don't have that much percentage for peripheral vascular disease. It's definitely smaller, maybe like 20-30%. Yes. Okay, but it is so important that even that 20-30% we identify. And then also what I see from my experience in DFO disease is that it is more neuroischemic ulcers that we find. Yes. rather than purely vascular ulcers. We have a few vascular ulcers, but usually it is neuro-ischemic, it's mixed.
Thank you very much, ma'am. So we'll keep on looking at that, and just like she has talked about diabetic foot ulceration, Nigeria is said to have the largest body in sub-Saharan Africa. Dr. Officer, I don't know if I can talk about
Well, because of our population, so the burden will always be the burden. So we have the largest burden of diabetes, and the diabetic foot ulceration, people have quoted point prevalence of 5 to 7%. Of course, it's more variable than that. But importantly, people say that the occurrence of diabetic foot ulceration reflects on the quality of diabetes care, maybe of health status in communities. And also the lifetime risk of diabetic foot ulceration is actually very high for a patient with diabetes. And it is said that most of the non-traumatic amputations that are done in hospitals are actually related to diabetic foot ulceration. So I think there's very little argument about that. And the cost is very substantial, unfortunately. It's prolonged hospitalization, the treatment is costly, there's a lot of impairment and disability, and then loss of livelihood. A lot of people, particularly if they get to amputation, they are unable to go back to the former occupation. And of course, we need to avoid that as much as possible. Sadly, for the diabetic foot ulceration as well, the 5-year survival post-amputation is worse than that of many cancers. So we can see that the consequences are not just medical, there's also economical and psychosocial. Imagine someone that is 54-year-old, father of the house, losing his limb. I mean, he's a bus driver. What's the way forward? So that's devastating.
Okay. Well, diabetic foot is one of my own areas of passion. Incidentally, I happen to be the president of Diabetic Foot Nigeria Initiative, and then also a board member of the Pan-African Diabetes Foot Group, and then Nigeria representative to D-Foot International. So we have been doing quite a lot of work on diabetic foot. I actually did a 2-year project in the FCT in 20 government hospitals, trying to empower the healthcare providers on, preventing and educating patients to prevent diabetic foot, and then we even brought in some faculty for podiatry, introduced them to some podiatry so that they can manage common diabetic problems. We did that for 2 years. And then I wrote a paper last year on the impact of education in reducing admission rate and amputation rate in our diabetes foot patients. It's an international journal for extremity wounds. It was 2020. So that's why each time I'm going back to the basics, because if these people are empowered, we can actually prevent them having this ulcer.
That's both the patients and the doctors.
Yeah, both the patient and the doctors. Yes, I actually have 2 books. One is a booklet for the patient to empower the patient to prevent foot ulcer, and then I have a handbook for the doctor on diabetic foot.
Thank you so much. We encounter a lot of patients that say, "Doctor, whatever you say." So if the doctor does not see, they will know to do. So that when the patient has gotten to the hospital, they have done a lot. At that point in time, we must not miss that point. Thank you so much. So let's talk about the pathology behind peripheral artery disease as a whole, and that includes how it affects diabetic foot as well. Sometimes it has been classified as both occlusive and aneurysmal. More often than not, we are talking about the occlusive types, but we must always remember that aneurysmal arterial disease also entails a significant part of peripheral artery disease. And the arterial media is weakened, that leads to dilatation of the artery at that point. Normally, at least 1.5 times normal diameter, and then those pieces will dissect rupture of those, which will lead to catastrophic consequences. Of course, sorry about that. Sorry about the break in transmission. Nigerian factor. So sorry about that. We're back on now. You will see us right now. You say they can't see us. You will see us now. We are back on now. Somebody says they are offline. So we're back on now. So good afternoon, everyone. So sorry about the break in transmission. So we are back on now. We continue our talk on diabetes, on peripheral arterial disease, as much as possible. So we stopped halfway into it, and while we're talking, and we will just continue for where we stopped. So while we're talking about the spectrum of peripheral arterial disease and what really happens. And we're about to talk about the pathology behind peripheral arterial disease. Those of you that are not in the studio here or in cardio care here, are missing a lot because a lot of side discussions have. Okay. So we're talking about the pathophysiology of and pathology behind peripheral arterial disease. Sorry about the break in transmission once more. Mr. Mohammed, if we have any problem with it, please go ahead of us and electronic representative. So we're talking about the pathology behind peripheral arterial disease. I would say a lot of times it could be occlusive. Occlusive could be thrombotic or embolic, as typically will happen. A lot of times the etiology comes in from atherosclerosis. Atherosclerosis is typically dominant cause. This is why cardiovascular risk factors are very important. But however, vasculitis, arterial injury, entrapment syndrome, some of the more dramatic cases we've had a lot of improvement from having from vasculitis and from arterial injury, automatic ischemia. The atherosclerotic disease typically have more diffuse disease across multiple segments. In our practice so far, we hope to put together our data. Dr. Gaffer will show us some pictures shortly, which we will see going forward. So, atherosclerosis, of course, is one of the leading causes of this. And in the lower extremities, muscular dysplasia, as we said, to occur typically outside the lower, but we know it also happens there. The muscular dysplasia is non-inflammatory and it's a non-atherosclerotic process where there is some hyperplastic cell growth of the lymph cell and cause luminal narrowing. It does not affect the renal and carotid arteries, but we know that it will also affect the lower extremities, and it's something to keep in mind so that we don't think that everything is atherosclerosis. And there are also risk factors. Also, can you have more constitution?
Risk factors of peripheral arterial disease, the commoner ones are just the usual suspects that we all know. Smoking, diabetes mellitus, hypertension, dyslipidemia, and inflammation, which can happen in many conditions, particularly in conditions like HIV, lupus, and several other conditions like that. Diabetes and smoking are perhaps the biggest risk factors for peripheral arterial disease. And it's always saddening when I see people with diabetes who also smoke. It's a terrible combination. Most of the ones I've met have been able to convince them to stop smoking.
I'm not sure they stop.
Many of them stop anyway. Not still struggle to stop. Unfortunately, the prevalence of smoking is increasing in Nigeria, but the younger one. So we need to do more to reverse that trend. Also, we have some less traditional risk factors. Most importantly, perhaps, is of the CKD. CKD can predispose to a lot of to rapid atherosclerosis and calcification of the vessels, which can almost be as bad as smoking and diabetes mellitus as well. Of course, hypothyroidism, osteoporosis, and have also been known to contribute as well to progression of peripheral arterial disease.
But in diabetic foods, beyond the arteriopathy that Prof has said, the other things that come into play, neuropathy, the deformity of foot, inappropriate footwear. Prof was telling us about someone that got a shoe and lost his life because of the foot to that shoe, because of inappropriate footwear. Even with previous application are also at this. We have people coming with the second foot here, which was very, very, very painful to us actually. And shows that I don't want to say that a reflection on our general medical care, but also whether the patient considered it serious enough after they lost the first pain. So some of these things are there, and probably are smoking on top. The duration of diabetes will also make a very big, have a very big role in terms of diabetic foot ulceration. So in addition to the peripheral vascular disease present, the fact that all of these others are there. Now, if they now have a deranged kidney function in addition to this, or problem with visual problems, it will also further increase the risk factors for diabetic foot ulceration.
Absolutely. So all these things that we mentioned now, all of them contribute towards the diabetic foot through various mechanisms. Like Prof told us earlier, the neuropathy, you cannot separate neuropathy from diabetes foot. It's very difficult to do that. Okay, so they can have both sensory and motor impairments, which both contributes to the risk of alteration by various mechanisms. The person that has sensory impairment, they can do some of the so-called prospective sensation, that's pain, temperature, and proprioception that enables us to take action to protect our feet. And of course, in people that have motor neuropathy, they have abnormal loading of their foot, which could predispose them to ulceration. And by the time we talk about autonomic neuropathy too, there's changes in sweating and dryness of the skin, which predisposes to callus formation, cracking of the foot skin, predisposes to ulceration as well. And of course, peripheral artery disease now goes through another link, which may or may not be prominent in a person with diabetic foot ulceration. But all these things puts the person at risk of a foot ulceration, and eventually the foot ulcers can develop depending on how well the person is taking steps to protect his or her feet, which depends on how well we have educated the patient. Yeah. And of course, foot ulcers often get infected in our own environment, which often complicates the issue. Prof, I don't know your comments on this pathway, man. The others
well, in Nigeria, so many things are peculiar to us. Many of our people walk barefooted. So, and they have lost that sense of pain or that gift. Pain is actually the sense of feeling pain is a likely to have the other. So this person may not be seeing well and is walking and then hits the foot against something and trouble starts. So then very interestingly, we did a comparison in the teaching hospital. We have a diabetes foot group in the teaching hospital, okay, composing of the endocrinologist, the orthopedic surgeon, the plastic, the orthotist, diabetes nurse, the microbiologist, and so on. So we carried out a study looking at comparing surface culture and tissue biopsy culture. And in both, what we do, very interestingly, were gram negatives, which is not the same as you find outside this country. And you know what our explanation is? That because, people go and defecate in bushes on the ground, so it's very easy now, walking barefoot to pick those things. And that's what we found in the cultures. So there are peculiarities to us. And of course, once neuropathy is there, I have said that about 70% of our patients with diabetes have neuropathy. Once that one is there, that is the beginning of symptoms. And of course, if the vessels are blocked as well, then infection now comes into play, and and before you know it, it's there with gangrene, or with three webbing, and we are battling with it and now deciding what to do. So that's why I'm saying that education, diabetes education is the most important actually for our patients.
Okay, so we see a lot of cases in cardiac care, and like Prof has said, in tertiary hospitals, they are also there abundant, coming with different ranges across the spectrum. It's very important that everybody understands that it's a spectrum. Okay, so patients hardly just come with gangrene. There were several other things that happened for years before. And one of the goals of this webinar got through by cardiac care and nutrition is to make sure that we start recognizing those things early and we start acting. We have looked at risk factors. So there are some people you must definitely have an extra eye for. If they have diabetes, if they have hypertension, if they have chronic kidney disease, if they have that, you all have to have an extra eye. If they're already complaining of angina or something else, you have to have an extra eye or ear for this. So it will be good. I think we'll perhaps consider that study of how peripheral artery happens in chronic kidney disease patients, diabetes. Presents in the clinic.
Okay, so most patients with peripheral arterial disease, most of them are asymptomatic, and that's the catch to peripheral arterial disease. Most of them are asymptomatic, and that intermittent claudication that we're taught in medical school is a very fancy term. I like the term, but a lot of them will not have it. And many people that will have symptoms, many of them may have atypical symptoms. That is, may not sound like that. You walk a fix, maybe you walk a certain amount of kilometers and you start to have the pain, and then you rest a bit, the pain is gone, and it keeps on cycling. That's all it is. So there's only a small minority of patients that will have the intermittent claudication, and then even a smaller minority that may present with critical limb ischemia, which either they have rest pain, ulceration, or gangrene, and then sometimes we have the acute limb ischemia, which is actually not quite common. Okay, but sometimes we have the acute limb ischemia. So patients present with that spectrum. And of course, we know the intermittent claudication. It is, I don't want to talk about it actually, but they can have pain, ache, or cramps during exercise, and it's often relieved. It's often relieved by rest. We have the so-called Leriche syndrome, in which they have a distal PAD of the abdominal aorta extending to the iliac artery and the femoral popliteal vessels, and they can have the child of claudication, impotence, and absence of femoral.
Well, of course, even as we are talking about this, the number of patients that are coming with impotence or erectile dysfunction is already something that you need a red flag. So don't just start thinking of Viagra, then that is already an indication for you to do a cardiovascular workup, examine the dorsalis pedis, examine everything down. Okay, please go ahead, sir.
No, absolutely, absolutely. So this just shows again the spectrum, and like Dr. Seko mentioned earlier, it's always a spectrum. And our aim is that we are able to pick it before it gets to this last part of the arrow where we have gangrene and core. We want to pick it early when they're just having this perhaps vague symptoms. We pick it early, we examine the patient, we optimize their cardiovascular risk, you educate them, and then the patient never gets to that end of the spectrum. That is what we want. Of course, there will always be some a few patients that get here and then that needs a more intensive treatment. But if we do what we want to do well, then most patients should not get to that limb-threatening part of the spectrum. Of course, there is always, neuropathy is very common, like Prof said. And many times, a lot of patients actually do have maybe a combination of neuropathy and ischemia. Some people have predominant ischemia, but it's being mixed up with a neuropathic pain. So we'll just talk of some of the things we can try to use to distinguish between someone that having neuropathic pain and ischemic pain.
Does this distinguishing, does this differentiating factors, do you actually hold true in clinical practice, or is it purely academic?
It is mostly academic, actually. It's
Prof,
mostly
I don't
academic.
know what your view.
Well, it's academic, but I think even clinically, they are still useful. They can help. For example, I mean, if you look at the limb of the patient, and we have an orthotist in a teaching hospital, like I said, we check the pressure areas of the foot, with the podesta. And you see areas of pressure. Now, if you prescribe the right therapeutic shoe to avoid excessive pressure in those areas, then ulcers will not wake up. Okay, so and the symptoms, if it is purely vascular, even looking at the limb alone, looking at the skin alone will give you that information. You get my point. So it's still useful, even clinically.
Dr. Please go ahead.
Okay, so absolutely, it's very useful, and we should marry the history to the clinical examination. So for if you have more distal pain, perhaps in the sole, perhaps in the back, it's more suggestive of neuropathic, and especially for ischemic, it's often worsened by walking and by elevation. Neuropathic pain is often worse at rest, but we should put in mind as well that ischemic pain sometimes the act of putting it on the bed from a dependent standing position can make it slightly worse. And some of them too can have pain at night, but that should be rest pain, and that should be fairly severe disease, and those people should have some clinical signs that can peak at the bedside. Neuropathic pain is often worse relieved by walking, so most people tell you that by the time they do the exercise and move around a bit, it's better, and it should be part of the treatment that is actually prescribed with people with peripheral neuropathic pain. But ischemic pain can often be relieved by resting as well. Also, the sites of occlusion can often be suggested by the localization of the pain. And of course, the classic one that we talk about in medical school, again, is the pain in the calf, which usually reflects superficial femoral artery narrowing or occlusion.
Okay, we'll have to move a little bit faster because of time. So these things will be there in the slides that will be sent to you after this. So just again, this webinar is on peripheral artery disease. We have Dr. Officer that will just need discuss. My name is Dr. Iseko and Professor Numa, a very renowned professor in this field, and president of the Active Foot Group for Nigeria, is here with us and giving us very useful insights. And we are talking from Cardio Care Hospital, which mainly hosting the webinar, supported by Medtronic. Medtronic supplies and helps with a lot of the devices and the things we use when we want to have invasive care of the foot. But right now, like we have said, we should make sure that we are screening, we are taking a good history, we are taking time to examine, we are taking time to educate. A lot of times clinics can get busy and people are rushing through the clinics and you don't have that time to sit down and educate. It may be important, and a lot of clinics have begun to have this hours to have dedicated educationists. So if the doctor is moving to, somebody can sit down and talk in the language that the person understands. Oh, God, this thing they do like this. Most times doctors are speaking too much grammar, and the patient cannot take anything home. You know, so if that is a very good way to collaborate and make sure that this comes up. We've talked about peripheral artery disease in diabetes and that the presence of neuropathy is there. So there are some things we must examine very carefully. Prof has already talked about smooth, shiny skin, hair loss, ticking nails, discoloration. If you don't forget anything, please look out for this. If you have any diabetes coming to your clinic and you have never checked any of these things, then today is the day you should change.
What I tell my patients is that if another doctor happens to see you and will not examine your limbs, ask the doctor, are you not going to look at my feet today? that's what I tell my patients. Yeah. Tell the doctor, are you not going to look at my feet before I go? Are you getting me? Because it's so important that there was a slide you showed about the symptoms when you were asking me whether these symptoms actually clinically apply. Yes. Much of it is history.
Yes, indeed.
Meaning we have to take detailed histories. Because by the time you ask those questions and you get an answer, you get a yes to anyone, you know that something is happening, and then you now have to examine to confirm what the person has told you.
Sometimes we've had people referred, and they referred as DVT. I don't know, Dr. Dafe will remember a lot of those cases. And just ask the patient this question. The question was, then we touch the limb, and the limb is cold, ice block cold. So they said, no, the ultrasound said, and so everybody just moved in line with the ultrasound. So going back, as gadgets are increasing, we must still not forget the importance of clinical examination. Dr. Officer, maybe we can continue about the other things.
Yeah, absolutely.
Just to
yes, ma'am.
mention here that actually diabetes education is a specialty. And we are starting a master's program in diabetes education in the
Wow.
University of Abuja.
That would be great.
Yes.
That would be great. And we'll look forward. Kanye will be very happy to partner and send people because it's a
Because
real
we formally
need.
train people for it.
Formally.
So that we have certified diabetes educators
Oh,
in Nigeria.
it would be fantastic.
Yes.
We try and do that informally for people to train, but it would be good to have subsets, nurses,
Yes.
even community health workers, people that can speak the language of the people, not just we that know it. So Borgia's sign, Borgia's test.
It's just elevating the limb in bed, but it's more useful in Caucasians actually because the pallor
The
and
black skin, you may not see
you
it.
not see it, you not see it, you not see it.
What about the 5 Ps? Like that's what the case I was trying to talk about, the 5 Ps.
Yeah, the 5 Ps is still valuable.
It's very valuable.
It's valuable. So
Yes.
the first lack of pulse there, lack of pulse there. We should all develop the skill and the fluency in checking for the dorsal space and posterior tibial pulses. You should be able to check it within a very short moment, so that at least we'll be eager to check it. The paralysis, they are not willing to move the limb. They can have paresthesia, which sometimes can be confused with neuropathy, and of course they can have pain and they can have pallor on the limbs. Just like the Borgas test, the pallor may be difficult to tease out in black patients.
Very light complexion.
This is very important. By the time the patient comes with this, you need to check. This can make the difference between saving that limb, especially in acute limb ischemia. The patient is having pain, the place is cold, and you touch it, they say it feels like everything, and the patient actually say these words. But if you're not looking out for it, you will not find it. What I want to challenge you today, everybody watching us, we have close to 180 participants now online. I'm happy to have it posted by cardio care. Is that the next 20 patients that you see, make sure you check the dorsalis pedis. You cannot learn how to check dorsalis pedis without checking. Some you will not feel, some you will feel, some you will not feel. Then eventually you will master the skill. So that when you say it's not there, it truly is not there. It's not that you could not feel it. So this is the assignment that we have for you. We know statistically that only 10% of people will do this assignment, but at least.
Actually, what I do with the medical students and the residents, if anybody clerks a diabetes patient for me and have not done examination of the lower limb is categorized as a system.
Yes.
The way we examine cardiovascular system. So if you have not done a neurological and vascular examination of the lower limb of this patient, you have not clerked this patient. So that's the rule, and everybody knows that.
So I'm sure all of us that are here are taking this back, and it's going to influence our practice and our patients significantly. Remember to characterize femoral, popliteal, dorsalis pedis, posterior tibial as much as possible. Auscultate also for bruise. People tend to forget this. Auscultate for bruise in the groin, in the abdomen, palpation from aneurysm. Sometimes we are picked aneurysm just by palpation. The person has gone everywhere, they are taking ulcer medication, nobody has put their hand there or just this, and it's massive about to rupture, and this can make a whole lot of difference. So a complete examination must include carotids. Please don't forget. You have found there's peripheral vascular defect, and that clinical evaluation must go on to involve cardiovascular exam. There are different stages. This is Rutherford and Fontaine stages.
Absolutely. So, so the Rutherford and the Fontaine equivalent of it. The main thing is to know that it can be asymptomatic, which we have said earlier that that's where most patients fall into. They can have various degree of claudication, which is graded as 1, 2, and 3. But by the time they're having rest pain, it's 4, and from there we have critical limb ischemia. They can also have ulceration and gangrene from there. So, but we want to be able to pick the patient whatever stage they are in, and of course, each of these stages has various treatment modalities that will be recommended for it.
So before we go ahead, I want us to just answer some of the questions in the box, and then we'll take a poll. First question is sickle cell a risk factor too? And how do we measure this ankle pressure you talked about?
So sickle cell being whether in risk factor of peripheral arterial disease, I'm not quite sure, but they are a risk factor for critical limb ischemia because they're prone to thrombotic events. But whether serious atherosclerosis is going to increase, but I think we'll say it's a risk factor as well.
It's a
Since it
risk
can cause
factor.
critical limb ischemia.
It's a risk factor.
For it.
And it's shown up very high on what do you call it? Population surveys as being one of the top risk factors. Maybe not as high, but maybe contributory. And don't forget that most of the studies that are done, very little have been done population-wise in peripheral arteries in the areas where sickle cell is predominant. So I don't know whether if anybody has done any work.
Thrombotic stroke. So what is happening in the cerebral vessels can also happen
in the peripheral vessel. Thank you.
So
And I know they are prone to ulceration as well.
The ankle pressure measurements.
How do we measure it? So the way we measure ankle pressure is usually during the ankle brachial index, and you put the cuff on the leg just above the ankle, and of course you inflate. So you do it using a mercury stick and a handheld Doppler, a 8-arc handheld Doppler. The handheld Doppler is almost just like the Doppler they use for obstetrics, okay, but the frequency is different. So basically you just inflate and then you palpate with your hand to estimate the systolic, inflate above that. But instead of now listening with your stethoscope, you use the Doppler to pick the sound. So that's how to measure. So in doing the API, which we should still talk about actually, you check the pressures in both upper limbs, and then you check in the lower limb, checking both the dorsalis pedis and the posterior tibia, and you identify the systolic pressure, and you use that one to calculate the API. So doing that, you can know the ankle brachial index. That's by dividing the pressure of the ankle over that of the brachial. Also, you can pinpoint the absolute value of the brachial pressure, which you say that if it's less than, okay, sorry, thank you very much. We say if it's less than 50, it defines critical limb ischemia. So we can see this, you just put the cuff here, and then we do this. So we use that one to calculate the ankle brachial index. But you need a handheld Doppler to do it. The stethoscope is not so reliable for picking the.
If you don't have a handheld Doppler and maybe it's difficult for you to get in your hospital, consider trying the one they use for the women for obstetrics. It may give you an in-between. It may not be the very best, but better than nothing at all. I know a lot of questions. I know the next question that will happen is how can we do it if we don't have? Like people used to ask, how can we diagnose MI if we don't have a sick? Some questions I can't answer, but maybe you can manage and see. You may be able to get away with some of these things, and that will help. In that case, also your history and examination will come very well. So some people that from rural and working in rural settings, do you have anything to add to this?
Yeah, I know that palpating the vessels is actually not very. If you get blocked vessels, that's not an early stage. But at least we can do that. Even though the patient is not complaining of any symptom, at least check the vessels. If you don't have a handheld Doppler to assess objectively, at least look at the skin, look at the color of the nails, okay, and then palpate the vessels. At least that minimum they can do.
Okay, somebody asked, good evening, Prof, how can we get your books? So how can we get the books outside Abuja? So what we'll do, perhaps, we will try and get it, and then perhaps if you send a mail to the email you registered with, we'll see how we can make it available to you, and depending on how we can get it, either we can get soft copies or we can get hard copies to you outside in that regard. Somebody asked how you differentiate the pain from sciatica from the pain from peripheral artery disease.
Okay, so
and then what test can differentiate arterial disease from neuropathy and sciatica?
Okay, so the pain from sciatica from the pain of peripheral arterial disease. The pain from sciatica usually sciatica itself is usually a radicular pain coming, going, shooting down through the thigh to the leg. Pain of peripheral arterial disease can cause you something like that too. But pain of peripheral arterial disease is classically worse on walking. It's less common in the gluteal and the thigh region, but it happens there as well, particularly if you have a disease high up, okay? But usually worse with walking, classically. And of course, but you need investigations to distinguish between them. And that goes to your next question, which is what tests can we use to distinguish between these conditions? So that's straightforward as well. For peripheral arterial disease, invariably, apart from the examination things which Prof has finally highlighted, the ankle brachial index and also a Doppler ultrasound scan can clearly define for you and tell you whether it is there or it is not there. But for neuropathy, usually we depend on clinical examination using your monofilaments, your tuning fork, your vibration fork, and your cotton wool to assess light touch. Usually that should give you a fine index. But if you want to go further, sometimes some people can do nerve conduction tests, but it's more of academic.
If they also have a neurotestiometer.
Neurotestiometer.
Or biotestiometer.
Neurotestiometer. I can find it as well.
Okay, somebody is asking if people can be sponsored from the army. Of course, we'll talk that. Please kindly say more about CKD and peripheral artery disease. I think this is nephrologist.
Okay, so for CKD and peripheral arterial disease, the key thing to say there is that you can have aggressive calcification of the vascular tree in CKD, and so all arterial diseases actually progress rapidly, both coronary, cerebrovascular, and peripheral arterial disease. So the prevalence is much more. I think it's going to increase about twice or thrice in CKD compared to equivalent people without CKD as well.
Imagine the person has CKD, has diabetes, and smokes. And one patient told me, doctor, you don't know how sweet it is. That's why you're telling me to stop smoking. I will continue. Prepare your treatment for me. But the important is that when they have CKD, it becomes a challenge in the cath lab. Because we have to give dye to be able to go in, it becomes very tricky, and the problems do so, the nephrologists have to stand back. We're going to put a poll now up, so I want you to answer. Please answer, we're going to poll. So you see a poll now. Please, I want you to participate. We have 170 people on a 64-year-old woman diagnosed with limb ischemia. Which of the following is true? A, most patients with peripheral artery disease have intermittent claudication. B, coronary artery disease is more common than peripheral artery disease. C, most patients with peripheral artery disease have moderate to severe symptoms. D, revascularization procedures should be reserved for those with established gangrene. And E, none of the above. So let's pick. Let's pick. Make an attempt. Don't be shy. We don't know who's answering what. If you miss it, we will not know. So make an attempt. Well, if you don't attempt, you will not have exercised yourself. Good, good, that's good. We have about 20% of people that have attempted so far out of 170 participants. Great, great. Great, great. So we're stopping the poll shortly now. In the next 5 seconds, once we get to 50%. Good. Let's keep on trying. Let's keep on trying. Should I dangle money over this pool? Wow, wow, wow. So we have about 53%, 54% of people have attempted. So we'll stop the poll now. Dr. Officer.
So most people actually felt that most patients with peripheral artery disease have intermittent claudication, but we'll try to disabuse that this afternoon.
We talked about it. Well, that's the usefulness of the poll, so that we can.
Okay. So most patients with peripheral arterial disease actually don't have intermittent. They don't have any symptom actually. Most will not have any symptom. Most will not have any symptom.
Which is why we talked about taking your history again and examination. But good.
And then coronary artery disease is actually not more common than peripheral arterial disease. Peripheral arterial disease is more prevalent than coronary artery disease, even though maybe the consequence of coronary artery disease may be more. So the answer is actually none of the above. Revascularization is probably too late when there's established gangrene. The limb is gone. Okay, so
as much as possible, we like to do revascularization in cardiac care before the gangrene sets, as much as possible. So we want you to make the diagnosis. The patient comes in early, they are fine, their kidney function is still fine. Then the revascularization, we get a very fantastic result. And we have some from very black, dark toes to fantastic, good, very fantastic at that point in time. Cardiac involvement accounts for a majority of deaths in peripheral artery disease. A majority of deaths. Relative risk of death from cardiac causes is more than 6-fold. When the patient already has a ailments and now has peripheral artery disease, we are very much more afraid. In fact, when somebody has peripheral artery disease, it's considered a coronary artery disease. Meaning, if you have patients with that, we'll already be thinking their coronary vessels could be blocked. This is some bad picture of diabetic foot ulcer came in late. At this point, trying to revascularize can be challenging, if not impossible. Okay, so this is quite gory, yes. So remember how the anatomy and physiology flows and how the blood supply flows. And the chance of vascularization is better when the bigger vessels upwards, not the smaller vessels in the foot. And typically when you have discrete lesions less than 10 centimeters, Dr. Adafe will talk more about that, so we'll just skip that. So back to food management.
Absolutely. We should be very aware of the foods at risk. And like Prof has told us again today, nobody with diabetes should leave your office without you inspecting their food. Take off your shoes, and the patient should be used to having to take, just almost the way they roll up their sleeve for checking their BP, and take off their food so that you inspect their food. And also inspecting the food also will remind the patient that the food is important, and the patient will likely pay attention to their food at home. So once you early identify the food that is at risk, apart from that, in patients that we've identified to have high-risk foods, it should be followed up regularly at the food clinic. Prof talked about a MDT team for diabetic foods, and those should actually keep assessing those kind of foods so that they're not just lost in the traffic of the regular patients in clinic. We, the healthcare providers, people with diabetes and their caregivers should be well educated about taking care of diabetes foods. And of course, our patients should know how to wear appropriate and sensible footwear, like Dr. Adele was it, sensible. And then there should be, so the footwear should be appropriate for whatever you are going to do. Okay, and then of course, we should teach them foot care. It's more than what I put here, but at least minimal moisturizing, safe nail cutting, a lot of things go into that. Checking their foot, checking their shoes before they put their foot inside. They should examine their foot each day, etc. And of course, whenever we have pathologies of the foot, either it's ulcerative yet or non-ulcerative, we need to escalate rapidly.
Okay, so sometimes foot assessment, look for deformities, check the footwear. Every time they come to the clinic, advise them on the footwear they are wearing. Check for the skin, check for callus. Do the check for neuropathy. Use your tuning fork. Tuning forks are disappearing from consulting rooms. They are coming out only in exams. Check with your tuning fork, monofilaments. And if you don't have monofilaments, maybe you can use a broomstick. I don't know. It's not ideal, but we have such a vast. What do we do, audience? Well, some people will call us. Some people will ask us now from different things.
Well,
what have they improvise?
They can use cotton wool. But of course, the most sensitive is the monofilament. But at least they will get some information with cotton wool. I think cotton wool is available.
It's available everywhere. It's available everywhere. Of course, check the dorsalis pedis and the posterior tibia, and as much as possible, do this at every clinic visit. Okay, and if patient already has amputation, that is already a red flag. Investigation should go the whole 9 yards. Make sure you look for all the cardiovascular risk assessments. Typically, for patients come to cardio care, we do what we call the cardiovascular risk profile stats. Once you come in, we check lipids. So even if it's first time diagnosis or long, we must have this full profile, and it's important. I know a lot of times we are constrained by financial situation in the country, but you need to remember that when the cost of losing a foot or of complication is much more than the cost of making sure that you check the risk factors and you address them properly and early. Okay. We talk about CKD. Somebody asked a question about CKD because I just remember the news here. And okay, we've answered that about the calcium phosphate product and the increased calcification and the rapidness.
So I just want to add something like what my teacher always said, that anytime you see the diabetic foot, and now anytime you see peripheral arteries as well, there's a jumble of other things about there. It's unusual for the urinalysis to be normal. UCR, you find abnormalities, CG, you might find abnormalities. So you need to go the whole 9 years, like Dr. Seko said just now.
Sorry, very importantly, when the patient comes with diabetic food, the tendency is to concentrate on that food.
Yes.
Please, I usually will discuss the apparently looking normal food first. Because if you identify that foot at risk and you educate the patient and empower the patient, you can preserve that one.
Yes.
But usually people ignore that foot that is apparently looking and all the effort is concentrated on. So we must always look at that foot that is looking.
In fact, it's one of the practices, if not, well, one of the things we consider, if not because of cost. When you are doing a peripheral angio, don't just do on the side that is. So sometimes people come with only Doppler of that side, or we'll do a CT angio only that side, maybe because of cost. Maybe we'll do a peripheral angio only that side, then we fix the problem. You know, before we had all the advanced things, we sent the patient one time outside the country. He had the same problem and he was looking for somebody to save the foot. They did not only do amputation of that foot, they did a prophylactic amputation of the other foot, of the supposedly normal foot, because of the extent of disease. So there was no point waiting for gangrene to come in. There was such critical disease that they did a bilateral amputation ahead and then fitted prosthesis. And sometimes that is maybe actually be better than struggling with this thing in that state for that particular patient who already had gangrene and had a lot of issues. There are a lot of differential diagnoses to consider. DVT is there, spinal stenosis, arthritis, and this is where the fine arts of clinical examination comes in. You know, this is where we internists like to be very excited. You know, come with your tissue, with your cotton wool, your monofilament, and your tuning fork and your patella hammer, and at the end say it is this or this or this. Very fantastic. Of course, you have to support with the diagnostic test. The ankle brachial pressure index, you should be able to do this in your consulting room. So let's do this. We are trying to rush for time, and we know we are not unmindful of your time. And Dr. Dafe has been doing press up, ready to talk about the invasive therapies. Dr. Officer.
Okay, so we've talked about this AB ankle brachial index. We won't dwell on it again, but we should know how to calculate it. Calculation is simple once you're able to measure it. And important to know is this category of people in which the ABI will be greater than 1.3. And it's common in people with diabetes because of the extent of calcification they can have, which makes the vessel non-compressible. And we should not be excited that the ABI is high and then it's good. No, it's a feature of a non-interpretable ABI, and you almost always need to do a Doppler ultrasound scan and other investigations for those kind of patients. Ultrasound scan, Doppler ultrasound scan is very available, even though of course there may be some inter-observer variances. Also, it is stressful to do because you actually need to patiently do ultrasound scan, put in gel all along the course of the vessel. Okay, but it's quite sensitive in picking peripheral arterial disease. And normal waveform, we should have a triphasic waveform, which you can actually also air with when you're using your handheld Doppler. Yeah. Okay, so when there's obstruction, it becomes biphasic, and when the obstruction is very bad, it becomes monophasic. And of course, the Doppler scan can also estimate the extent of stenosis by checking certain parameters. So basically, when we're suspecting that a patient has peripheral arterial disease, of course, next thing to progress to is our ankle brachial index. But whether or not you're able to do that one, you usually need to go and do the Doppler as well to define the extent of the problem of the patient so that we can manage as intensively as required.
What about stress treadmill testing?
Stress treadmill testing is not something that we routinely do, but it's something that actually has a bigger role because it correlates more with the functional state of the patient, actually, particularly when we're dealing with a patient that does not have critical limb issues. So, number one, talking about even asymptomatic patients, by the time you put down stress, sometimes you're able to pick some extent of abnormalities. So, we often will start the stress test for limb ischemia here, hopefully along the way as well. So, but basically, you check before, during, and after the exercise. And in these patients that have significant limb ischemia, the ankle pressure drops during the exercise instead of increasing. So, and it tells you, of course, there are some other functional tests that we can do, including the pain-free walking distance.
Okay, so the other thing, CT angiography is non-invasive. We give contrast, we do that. Typically, there's also a skill that has to go along with it. So sometimes CT is available, CT angio is supposedly done, and it looks like more like CT with contrast. Mm-hmm. So CT angiography and normally 3D reconstruction of that is quite important.
What I'll add to the CT angiography is that it should be reserved for patients in which you are considering intervention.
Oh, yeah.
So patients that have either critical limb ischemia or patient that has a non-healing ulcer. You don't do plan, doctor suggests that there's some narrowing, but you need to now see this narrowing very well to know that whether this person, whether you should intervene for this person.
And what level of intervention? Should you go straight to surgical? Should you go? Do you consider other things?
Absolutely.
Even if you are going to the cath lab for the conventional, you should have an idea what you're going to meet. So
Absolutely.
sometimes we've had those kind of things. I don't have money, I don't have money, I don't have money. Then you go inside and you meet much more than you established.
Okay.
I'm sure Dr. Dafe will talk more about that. It can be. So conventional angiography, which is a lot of what is also done here in cardio care. Essentially, we do either same side of contralateral, we use digital subtraction, there the cath lab. What essentially happens is that we put in, just like the way you take your blood sample, your femoral artery, put in the sheet there, sheet out, we put in the sheet, and then we go contralateral to the contralateral side. Inject the dye and we run through the the peripheral artery, and then it gives us a nice view like this. Sometimes we could do the digital subtraction, which is take away the bone, you know, so that you can see the artery very well to define it. I think the last case we did for peripheral limb ischemia was post-surgical, which had went in for, I think, an orthopedic surgery of some sort. Plates were fixed, and just above the plate, blood supply stopped, and below the plate. Unfortunately, in fact, it was not end very well at all. So it is important that as we're talking about atherosclerosis, we also put this in mind that even surgery, trauma could also be a major one. One we also did was post-gunshot injury, with insecurity along the road. It had multiple pellets. Maybe Dr. Edafe has some pictures to show us. And one of the pellets just stopped right there and below, on the vessel. Pellets were scattered over the leg. The pain was unbearable. The man had that thing for up to 1 year. Wow. But the pain in the limb was unbearable. A lot of collaterals had formed, but the pain of the rest pain was totally unbearable. Unfortunately, from angiography, you cannot remove the bullets from there. So it's at this point that we always see that this must always be multidisciplinary. Always, you must put in everybody. In the cath lab, not only the cardiologist or the interventional radiologist, the cath lab technician, the nurse, the ICU nurse, the physician, the endocrinologist, the people that will rehabilitate after physiotherapists. Everybody has to come into play, and it's quite important. This is what the cath lab looks like, and essentially what we do. What is in Mr. Ike's hand here is one of the kind of catheters that are used. So once we take a puncture here, then we take the catheter through to the other side, and then we image it. The patient is typically awake while we are doing this. We are monitoring the vital signs, pressures, and we are all wearing lead jackets to protect from radiation over time.
We need to.
Yes, so I think right now we will switch over to Dr. Edafe, who will talk about some of the invasive methods of management. But before that, remember that there are a lot of other things you can do. Antiplatelet therapy is important, statins is important, smoking cessation, and optimizing glycemic control. Remember that sinostazole can be used, but there's an increased risk of sudden death in patients with cardiac disease. So sometimes as much as 50%. So it's very good to also evaluate. You are happy now. Yes, there's blood flow. The patient is doing fine. All of a sudden, the patient was brought in there. So it's something to also consider while that. And then analgesics for pain. Education. Prof has talked about it, and we cannot emphasize it more and more. Education on that foot care. And, like we have learned today, also on the other foot care. The other foot has not shown anything, but sometimes we have found out that the other foot has not shown anything has worse disease than the one that we are running after. Okay, so Mr. Mohammed, maybe we'll take your presentation while Dr. Dafe is coming on. So Medtronic has a brief presentation, Medtronic International. Mohammed, over to you while we take the next presentation. And what we are looking at now, the next one is the action part. So don't turn away. This is the time when they kill the boss. We're going to go over to look at how the coronary peripheral is done and some of the cases and some of the interventions that we can do to help patients to save the limbs beyond all of this. But remember, this is 95% of what is supposed to be done. You know, remember that sometimes you can combine aspirin and clopidogrel. Yes, there are studies that combine aspirin alone, aspirin and clopidogrel and rivaroxaban together. And most people are tilting towards rivaroxaban combined with an antiplatelet, which gives a kind of a better outcome. But of course, you must remember that the bleeding risk must be weighed. And you must do the Has-Bled score and do the other thing that helps you evaluate the bleeding risk in this. Prof, I don't know what your take is on anything you have to say on general management, non-invasive management.
Yeah, I mean, I think you have essentially said, everything. It's just that, like you said, we have to be careful with yes, because you do a fantastic thing, patient is happy before you know it, something happens.
Okay, so Mohammed, over to you. Mohammed from Medtronic. Medtronic is a big company international. So let's stop sharing. So Mohammed, you can start sharing your screen.
Thank you so much, Dr. Seko. Can you hear me?
Yes, we can hear you.
Okay. Good afternoon, panelists. Good afternoon, Prof.
Good afternoon.
Yes, ma'am. It's a pleasure meeting you finally. And thank you so much for agreeing to be part of our presentation. Can you hear me?
Yes, we can hear you, but just speak a little bit louder.
Okay. So without wasting much time, so my name is Mohammed Gidado from Medtronic. Manage the cath lab therapy for Nigeria and Ghana. So I'll be sharing my screen shortly. So the presentation is meant to be done by our training and education manager, who is Bora Boss, but unfortunately he's on transit, so couldn't make it. So I'm going to be sharing a video of his presentation. Okay, so
okay, we're waiting for you to go ahead.
Yeah, so I think the IT guy needs to give me the stick to be able to share. Okay, Seko, can you hear me?
Yes, we can hear you. Try again now.
Okay. Can you see my screen now?
Yes, great. Go ahead.
All right.
Okay, we're waiting for Medtronic presentation from Ghana. Give us some international perspective and talk about Medtronic. Mohammed, your screen has gone off now again.
Can you see my screen?
You have stopped sharing actually.
Oh, okay. I think it's a problem.
So while he's preparing, we'll just be answering some questions. So we'll send you the slides for those that are asking about the slides. After this, we'll send you the slides, and subsequently the link will be on the Google, on our YouTube page, so that you can rewatch it over and over again at your own convenience. If you go to Google, if you check cardio care, you will find, go to YouTube and check for cardio care. You will find this and other presentations and explanations on ECG monitoring, different things that will be of value to your practice: MI, chest pain, hypertension, diabetes, OPD management of diabetes, including peripheral artery disease. And so you get all the slides. If you don't get the slides, please send a mail back to cardiocare symposia at gmail.com. Go ahead, Mohammed. Once you start, I will stop talking. I'm just trying to make sure that we use some of the time as well.
Okay.
So we'll send you to the email that you used to register.
Can you see my screen?
Yes, you can see your screen, but there's no video showing. Can the panelists share cardio care experiences of interventional treatment? Dr. Jaffe is just coming up and he'll talk about that. Mohammed, you stop sharing your screen again.
Now?
Yes, it's starting good. Great, great, great. Awesome.
Okay.
Okay, so while it's getting ready, we will perhaps continue with some other ones. So, Dr. Dafe, maybe we'll start off with you.
Okay.
While he's getting ready.
Yes, I think you said.
Okay, so there are many more questions in the chat box. Cardiocare should talk about the interventional treatment. We'll talk about some of them. We've had quite a number of cases, and we've learned a lot. Let me say that the presentation in Africans does not follow the books. Let me just say that clearly. And also, we've also learned how does ultrasound correlate with the findings internally. And what we are doing is giving the feedback, just like medicine improves when pathologists tell us what they found at the end. We feel that ultrasound will also improve while we find something totally different from, and that has, we've seen a lot of improvements, especially people that got feedback. So this means, so they go back and review what they've done. So while Medtronic is getting ready, Dr. Dafe will start off with his presentation.
Okay, so thank you very much. Every protocol duly observed, Chairman and my teacher, Professor Numa, thank you very much for honoring us, man. God bless you. So the second, thank you for the privilege. So we will use the next 20 to 25 minutes to run through the various options that we have for treatment of. Can you hear me?
Yes. Go ahead.
You can, okay.
Go ahead.
For the various options that we have for peripheral artery disease. So before I quickly talk about the options, let me use 1 to 2 minutes to discuss what we should know about the anatomy and the physiology of lower limb arteries. The abdominal aorta bifurcates at the level of L4, L5, and it created the common iliac artery. So the common iliac arteries they also divide to form the internal and the external iliac artery. The external iliac artery, as it crosses the guinal ligament, it becomes the common femoral artery. So the common femoral artery is about 4 to 6 centimeters. It then divides into, sometimes it's shorter than that, divides into the profunda and the superficial femoral artery. The name actually superficial femoral artery is a misnomer, but it's already given. There's nothing superficial about that artery. It's already given, so we call it that way. So once it crosses the adductus hiatus, it becomes the popliteal artery. The popliteal artery also have a course of roughly about 4 to 6 centimeters, sometimes less than that. Then it divides into the anterior tibial artery and the tibio-popliteal trunk. The tibio-popliteal trunk, it gives out the peroneal artery, then it continues down as the posterior tibial artery. So the posterior tibial artery goes down and forms an arc from the foot, while the anterior tibial artery will end up giving rise to the dorsalis pedis once you get to the dorsum of the foot. The most common, are we not?
Go ahead. Go ahead.
Okay. The most common or the most important artery of the lower limb, if you ask me, is the Profunda Artery. That is the most common artery of the most important artery. The reason is that if that artery goes bad, it is difficult for you to salvage that limb. The superficial femoral artery may get occluded, may get occluded in a very long way, in a chronic form, and at the level of the posterior, popliteal artery, you have the geniculate branches that are coming out and also connecting to the deep femoral artery. So if that superficial femoral artery gets occluded, from there you can have a lot of collateral and circulation that will open up and still supply that limb. Now, by way of physiology, the way to understand the physiology of the lower limb artery is, I'm not going into the detail because that is not the topic, is that we should know that the artery of the lower limb are resistant artery. They supply the muscles. So they don't supply internal organ like the kidneys, like the brain, like the heart. They don't do that. They supply the muscles. So there's a lot of resistance that goes on in the flow there. And that is the reason why when you put your ultrasound, your Doppler ultrasound, the first wave you are going to see is the systolic wave that shoots up here, then the diastolic reversal that comes, then you have another diastolic that goes up before another wave is formed. And when it's similar to when you image the external carotid artery and the internal carotid artery. If you image the internal carotid artery, you will see a wave that is very low because we are supplying internal organs and you don't need high pressure to do that. While if you image the external carotid artery, you will see a very sharp waves with high resistance flow. So this high resistance flow is maintained because there are a lot of acoustic shadows, a lot of vibration that goes on, and also resistance from the branches to the muscles. Apart from the particular artery you look for, there are a lot of branches that goes out to supply the surrounding muscles. And when the pressure comes, you have a feedback again that creates all these things we see. And when you are imaging that, you use that to help to look at the stenosis, with the changes that occur. But we will not go into that. Today we just talk about the treatment option for peripheral artery disease. Now, there are two things we should bear in mind. Number one is the acute limb ischemia. Then number two is the critical limb ischemia, because these are the points where most patients present to us. But at the level of moderate peripheral artery disease to severe peripheral artery disease, a patient that presents can also benefit from any of the options that we have. So for acute limb ischemia, once they present, one thing about acute limb ischemia is that either it is coming from embolic event in the heart, or maybe the patient had aortic aneurysm, it's at the level of the heart, the dilated heart, or atrial fibrillation, or any other thing that causes a thrombus to form in the heart and get migrated. That thrombus, once it gets to the limbs and it hangs somewhere, it blocks. Below that, it blocks everywhere, and the patient is in deep shambles. So that is an acute limb ischemia, or even within the point, within the arterial territory of the lower limb, from the turbulence of flow, a clot can form, and within that site, a clot can form, and you have a thrombotic event, which also form an acute limb ischemia. Sometimes it's a mixture of both. You have both. The patient already has severe peripheral artery disease now, because of the turbulences, clot now start gathering on it, and the two presentations now come.
That's combining the
yes,
both the critical limb ischemia,
yes, and acute limb ischemia. Yes, so sometimes you may not be able to separate the two. The two may go together. We have seen them several times. So analgesia is very key to manage them, because that also helps in easing the anxiety, because the pain is very, very severe and excruciating, then we can also give them heparin, which may come in form of subcute or in form of fractionated heparin, as the patient may tolerate as you go on. So in the 60 and 70, the balloon catheter thrombectomy was first introduced by Fogarty. Now, that Fogarty catheter is still used to date as we are talking.
Yeah.
Now, these are some of the options for open surgical techniques for salvage of the limb. It can be done by balloon catheter thrombectomy by using the Fogarty. We have it in our cupboard and we do use it from time to time. Or a bypass, you can do a bypass, look at where the clot is, then you bypass where the clot is using a vein or a conduit to bypass it. Or we can do end arterectomy, open up the vessels and you take out the clot and you suture back, but you may need something to patch it and in addition to that. Or you can also do intra-operative isolated limb thrombosis, as at that point when you do it for the patient. Well, I don't have so much time to talk about it. These are some of the balloon catheter used to withdraw an acute occlusion in the leg. I will show you some of the pictures very soon. Now, the catheter-directed thrombolytic therapy is an option that we use, very widely used, and we still use it here. So here is that if it is happening in one of the legs, you can come from the opposite leg contralaterally, take an access to the contralaterally, you pass your catheter to the point where the aorta bifurcated, you direct it to the other limb and you push it into that limb. But before then, you have made your multiple fenestration on that catheter. Then under that, you set up your infusion medication, either Arteries or tenecteplase or streptokinase, any of them. You can set it up, and once you set it up, you infuse it over 6 to 12 hours to 16 hours. So you do that gradually so that that little drops of it that goes into that leg helps in breaking up the clot. While doing that, at the point where the sheet is, you can be heparinizing it using another infusion to heparinize it so that clot will not form, because these are all foreign body. Clot will not form on that particularly until you go back and take another angio, or you can do your catheter, Fogarty catheter thrombectomy for the patient. Always look for the contraindication before you move into that. If they are there, try to see whether are they relative or absolute. And you always discuss with as a team with the surgeon, and also with the endocrinologist and every other person, the cardiologists that are there, for us to have a uniform decision to make a progress for the patient. So that helps a lot. Then other things that also came up over the years are some devices, the angiojet rheolytic catheter. You pass them to the point where the clot is. We don't have them in Nigeria. And you inject fluid under high pressure on those clots. So it dislodges the clot, then you can suck them out directly. The disadvantage of that is that that high pressure of where you inject that fluid, where that fluid flow, that saline fluid flowing under high pressure can dissect the artery or rupture that artery. That is just the disadvantage of that. But what I usually say is that whatever that you are used to, always improve on it and keep using it. Here we are used to the catheter-directed thrombolytic therapy, and it does a number of good things for us in acute limb ischemia, including Fogarty catheter. You can see this case that we show here. This was a woman, a 68-year-old woman who presented to us with an acute limb ischemia. And how do we know the diagnosis? The cardiologist who saw her in the town where she was called us that within a day, the lady just noticed that the leg is becoming very cold and very painful. And it's not swollen. That is one key thing about it, because acute limb ischemia happens very abruptly. It's not swollen, very cold and very chemically cold and painful. And as the lady came, the skin is colder than the ice block in the fridge. It tells you that there's no blood supply to that limb. So we called the surgeon and the vascular surgeon, and our plan was to use Fogarty catheter. You can see the Fogarty catheter by the side here. Our plan is to use the Fogarty catheter and take it out. So we went from the popliteal area. Now the popliteal, so we lie the lady prone, and the surgeon exposed the popliteal artery. Then when he exposed the popliteal artery, first thing we did was to go down and take out as much as blood, then go up and take as much as blood, then before, then establish a flow.
But this was after a conventional angio.
This one, we didn't do an angio.
We just went straight.
Yes, we just went straight because the limb is already, there's already an ascending angle that is already coming. So we wanted to just save the patient as much as possible. So these were the clots that we took out. You can see them around here. So this one is another case that we also took, the surgeon and I. What happened here was a patient, this patient is, I think 92, Papa was 92. The same thing, he was admitted to a hospital, he has been there, he has AFib with a dilated cardiomyopathy. Suddenly, the left limb just suddenly went very cold. And what did we do? When we are called, we just gathered ourselves together and we went in. Here, this is the superficial femoral artery that the surgeon exposed here, the vascular surgeon exposed. So we went towards the feet and take out as much clot as possible. Because when you go up and take up the clot, then what happens is that blood flow will come. So go always this way, finish with this way, then go up. Then the aim is just to maintain muscles. Then the surgeon close the nip he make on the artery for you to enter, then you move on. So what will happen is that we wanted to go up and notice that we're having resistance as we're going up. And even when we took out the clot, we're not getting enough, we're not getting flow as we're supposed to. That pressure flow, we're not getting it. So what we did is that we get to the guinal ligament, the surgeon took another exposure there to get to the artery. Then we now push the catheter down, then take out the clot before we could establish a flow. And that limb was salvaged for that particular patient. These were some of the clots that we took out. So for critical limb ischemia, Dr. Seko and Dr. Awobisoye has made a very important discussion on it, and our prof, Professor Numa, has already told us all the things that we ought to know. So what we do here in the critical limb ischemia is that when they come, the first thing is that should endovascular be offered, should no revascularization be offered, or should we do a hybrid? A hybrid is when you combine endovascular and surgical. That is a hybrid. For example, if you don't combine, there are some people, if you don't combine the endovascular and surgical, you will have an amputation that is almost close to the hip. Sometimes you can revascularize to below the knee and save the knee joint, because the knee joint is a very important joint. And if you are using a prosthesis, if you are offering the prosthesis to someone below the knee joint, it's more palatable compared to the one that extends almost throughout the entire limb. So you can see that it depends on what the stages are and what you are looking at, and you discuss with the vascular surgeon or the endovascular surgeon to agree on what to do. Also, it's very important that it is not only the cardiologists or the endocrinologists that manage critical limb ischemia. The vascular surgeon, the podiatrist, is a barrage of almost everybody who care for that limb. Even the orthopedists are all part of us to manage that limb. Infectious group of people are all there. So what do we do in critical limb ischemia? You said that we talked about revascularization. Now, for the revascularization, what are the options we have? Is it a bypass? Is it endarterectomy, or are we doing endovascular? So for the endovascular is very important for us to do for that. If the patient is going for that, we can do a balloon, yes, angioplasty, Now, the aim of the balloon angioplasty, depending on what you are seeing, the aim of the balloon angioplasty is this. If you offer the patient even only balloon angioplasty, that limb, that particular artery may still close by, but it will take a longer time to close back again. So at that point in time, it's expected that more vessel must have spring up to save the lower limb compared to the one that happened acutely where the patient had no time, where the body has no time to develop whatever that is there. So
collaterals.
Yeah, collaterals to happen. So that is why the balloon angioplasty is important. So you can do balloon angioplasty, you can do a cutting balloon, you can do drug-eluting balloon. The drug-eluting balloon are being coated. The balloon is coated with paclitaxel, sirolimus, or zataralumus. Now, when you inflate it, you will wait for about 3 to 5 minutes, so that while it remains inflated, so that the drug that is coating the side diffuse into the surrounding. So that also helps it helps the patient to keep that vessel more patent for a longer time. Then we also talk about stents. Stents, basically we have two groups. We have the self-expanding stent and the balloon expandable stents. Then we also have the drug-eluting stents and the bare metal stents also that also cover. They also have the cover stents in case you must always have them in your shelf. Then the bioabsorbable group of stents are also very important. Then we also talked about things like debulking devices, like arterectomy devices. Now, these arterectomy devices are reserved for people with calcified lesions. Now, if the whole vessel, for example, you do an angio and notice that the whole of the superficial femoral artery is totally occluded and is heavily calcified. If you just go and put a stent, it may not expand. Yeah. So you need arterectomy to cut through the calcium. You cut through it before you go and deploy your stent. Or you can use your lithotripsy. That is the latest now we have on board. So lithotripsy it does a lot of wonders. So you can use your lithotripsy and you use the ultrasound to break out the calcium. Then you go in and you take your rotational arterectomy and break them up, then deploy your stent. So in that case, the whole of the SFA may just be filled up with that stent. So those are very important. The cryotherapy, the gene therapy, stem cell transplantation. Some people have also tried that. So here you can see that here is the intravascular lithotripsy. So you pass the catheter to where the calcium is, where you have those heavily calcified calcium. Then you inflate it to about 4-5 atmospheric pressure. Then, because this thing, they come in the form of a pack. You connect it to the machine, then you take the sound and you generate the sounds and you break away the calcium. Once you break the calcium, you'll be able to expand that vessel and put your stents and move on. So these are all things that have actually come in for us to use in people with critical limb ischemia. This case is a lady who came from Edo State. Mama was diagnosed with critical limb ischemia, and she was told that she's going for amputation. Mama, you know, our environment is more of a cultural thing. People refuse that. The first thing they will tell you that over their dead body, God forbid, you can't take out my leg. And knowing very well that maybe they will still come again, you know, another life. If they cut off the leg, the leg will not be there, you come again. So Mama refused. And we called us, and when they came, and what we did was this. You can see the leg. Funny, he has bilateral critical limb ischemia. So one here, you can see one here, one here. So when we took the angio, you can see that this one is on the right. You see, this is the SFA. so diseased down. Then this also this is on the left. This is SFA, the same problem down. So this is at the level of the foot. There are still some circulation down to the level of the foot. So what we did was we ballooned those SFA, we ballooned all those areas that were critically stenosed. Then allow a time, then put the lady on medications. And after 3 months, the whole leg, that is the wound's ulcer, while the wound continued, everything got healed. And it was like a miracle for Mama.
Of course, don't forget that medical therapy must continue.
Yes, you are
plays
right.
a very big
important
role. You still have to rest that foot.
Yes.
So Mama cannot start, putting everything.
You are right.
Those risk factors we talked about must also
maintain. Yes, you must keep treating them and treat them to target goal. Very, very important, sir. Thank you very much for that. So this is another case. This case had a case, I hope it's playing, yeah. Oh, very good. You can see where the stenosis is. This is where the stenosis is, just at the popliteal artery. This, it came in with resting pain on the lower part of the thigh. That was how she came in, and we had a superior stent. Superior stent is a vascular magnetic stent. It's a stent that you can use across a joint. Not every stent that you can use across a joint. You must use a stent that when you bend the joint and you move freely at the joint, the stent will not fracture. So superior stent is by Medtronic, and there is one of the stent that does that wonder. So we put it for her. And next one, sir. So this was it's a self-expanding stent. You can see us crossing. This is under road map. Where you see this picture, this is road map. So we just cross it. Then the next point is the stent deployment. Yes, next one, sir. Okay. Yes. So you can see, we can see that, yeah. So we'll pass it. Now the stent is now being deployed here. Yeah. So this is the deployment of that stent just behind the knee joint. So to cover that area. The reason is that by the time if this stent will get its stenosis, then the body has readjusted itself. It will take some time. You still continue your medical therapy. Next one, my time is some process. As almost gone. Yeah. Next one. Yes, so this is after post-stenting, and we got a good result.
And then
yes.
You have to flex the knee.
Yes, you have to flex the knee to be sure that
the stent does not break.
the stent doesn't break. Because that is, tomorrow if they take you to court, you will tell them this is what you did, and no, you will be exonerated totally. Yeah, next one, sir. Okay, so this another case, we have it, and this man had a very tight stenosis at the bifurcation of the iliac artery. It was a very difficult case, and we went through it. So we had two access, one from this side, one from the left, one from the right. That was what we did for him. So access from you can notice that the tight stenosis is here. So, and this is the carina where the bifurcation of the abdominal aorta is. So this is where, so we took one here, put one stent here, put another one here. Yes, next one, sir. Very good. So we now took a balloon and tried to balloon, one balloon from here, from the right, one from the left. We flip them at the same time to ensure we put pressure at that point, because we didn't have rotational arterectomy to cut across the fascium. So we use that to avert that. These are NC balloon, non-compliance balloon. So they also give us a very good result. Then after that, we took the stent, the two stents at the same time, and deployed them at the same time. Yeah. Next one. Good. Yes, sir. Very good. So we deployed them at the same time, and we had a good result. Before now, he could not. There was no palpation of the femoral artery. We punctured the femoral artery under fluoroscopy because we couldn't palpate it because there was no significant flow to get a pulse to your hand. So, and we got a good result for her. Next one, sir. Good. No. Okay. So, Complication of arterial revascularization, well, we can have reperfusion syndrome, hypertension. If you revascularize into a dead tissue, you may get all these things out of it. So compartmental syndrome, ischemic neuropathy, muscle necrosis, and the rest.
And
But
of course, this is normally worse when the patient already has gangrene.
exactly, you are right. So this is a Fogarty catheter while we are inside the cath lab. Thank you very much for listening. If there are questions, we answer. Chairman, over to you.
Okay, thank you very much, Dr. Edafe, for your presentation and the fantastic work that you are doing in trying to save the limbs of our patients. It's been quite exciting. So I'm sure there are questions that.
Okay, before we go to the questions, we have about 10 more questions to answer. We'll answer all of them. Just we are going to end in a few minutes time. So Mohammed, can you go ahead with your presentation, please? Mohammed, can you go ahead with your presentation, please? I can see different consultants and professors here. We are very glad to have you. Thank you for joining us. Mohammed, yes, we are seeing your screen. Go ahead, Mohammed. We are seeing your screen.
If you send the slide to Pamela before.
Since it's very difficult.
Can you see my screen now? You can see the video?
Yes, we can see your screen. Go
Can you see the
ahead.
video? Okay.
Mohammed, what's happening? Okay, while you are sorting your slides, we'll just be answering some questions. Is there any difference between atherosclerosis and atherothrombosis in peripheral artery cases? Dr. Dafe, you want to?
Yes, when you say atherosclerosis is, thank you very much, sir. Atherosclerosis is a narrowing of the artery by buildup of arterioma on the from the intima of the artery. It bulges into the lumen. The thrombosis is when there is a clot formation. Usually, they may go together in the sense that when the patient has vulnerable plaque, and that vulnerable plaque gets ruptured, the platelet binds to it, and you now have a clot formation occurring. So you talked about a thrombosis that is occurring there. Most times in MI, it happens. Also in the peripheral artery, it does happen too. So it's not only the coronary artery where you have that. You also have that even in the peripheral arteries.
Mohammed, once you're ready, just start. We'll continue answering questions. Once you're ready, just go ahead and we'll stop answering questions. Are endovascular techniques useful in established diabetic foot disease?
Yes, the answer I would say is yes, because endovascular techniques are the part of management of diabetic foot disease. Yes, yes, very correct.
So, what I would just stress about diabetic foot disease is that a lot of times it is better before gangrene. Let me just say that again.
Very important. Yeah.
So, like Prof has emphasized, between the history, the science, the earlier the better. So, revascularization can be done early before there is tissue loss, gangrene. Remember, we showed a lot of complications. Before there is ulcer. Even before there is ulcer. Yes. So the cases that we have highlighted are the ones that they did not have ulcer. Fantastic results. Now, when there's any tissue loss and gangrene, once you start, you are going to have problem because the risk of kidney injury, hypertension, myoglobin is very high, and so all of that. Once you are ready, just start. And so some of the things are quite important. Please go ahead.
It's not.
Okay.
We're seeing the slides, but we can't hear.
We can't hear you.
Okay. I'm not able to put on my video.
Audience, are you hearing the video very well? If you cannot hear the video, let us know, please. If you cannot hear it, no volume. Okay, so I'll just talk as the video is playing. I'll explain it. So they are Medtronic has a peripheral vascular portfolio, and industry leader in the vascular treatment, especially here in Nigeria. I've said that they are the key partners that partner with us in terms of providing some of these solutions. These are the same international solutions that all over the world. So it's quite important that they are here to support some of the work that we are doing. You can see EvoFlex as one of the things called the self-expanding stent, and that has saved us quite a lot. In fact, it has done a lot of work for us. Now you see that in the peripheral arterial options, they have a lot of things offering, and some of time they have simulator workshops, they have carotid artery stenting training. So some of the training facilities are also available, and we cardio care partners with them in some of the training that is available for patients. In dialysis, we could see that AV access and preserving dialysis lifeline could be used for fistula stenosis. So when you're putting an AV fistula, sometimes for kidney disease patients, that could also be done. And this is all the spectrum of peripheral artery disease. And when we do limb salvage, a lot of these catheters and balloons are quite critical. In fact, you cannot walk without them. That's the truth of the matter. Yes, there are other companies, but Medtronic is leader in the country currently. And these are one of the things that they are showing forth. So you see, if you can see the video as they are showing the different slides and offerings, that's showing the different techniques and things that are available of their stents. Yes, costs are an issue sometimes, but you have to think about the fact that the balloons are drug coated, and what you are trying to do is to save a limb. Dr. Officer talked about the socio-economic impact of this disease, of peripheral artery disease, and this is quite important. They have robust clinical data backing a lot of the work, and almost virtually all their devices are FDA approved. So it has gone to several levels of scrutiny. So I'm trying to talk on behalf of Boss Bora, as we cannot hear his volume very well, as we're looking at the slides. So this is quite important. There are a lot of challenges we face here in Africa, and some of these, once you have the right tools at your hand and the right training, which sometimes are available, this can be very effective here. In partnership with Medtronic, we're able to, cardio care and different other centers are able to provide a lot of these treatment options for the patients. And that patients coming from the entire northern Nigeria, southern Nigeria, coming from different parts for limb. Truthfully, it's not every case you can salvage, and we must keep that in mind. Some cases have gone too far. There's so much gangrene, and people are saying they must not have their legs cut off. They must die with their 2 legs. Those typically are the most challenging. Sometimes you have very stubborn clots, resistant to thrombolysis, And because of the extent of the limb ischemia, will have acute limb ischemia, may not be acute, prof. It may be 2 weeks of acute limb ischemia.
Yeah.
So by the time you open up, you have reperfusion injury and a lot of it. So some of the things that are faced here in the country. So you see that there is a lot of bypass options, and all to prevent amputation as the end point. But we must remember, as we are saying of this, that amputation is still a treatment modality. Let us not shy away of it, because it could also be life-saving. There's a tendency for people to say, okay, now we have all of this, we will never cut off any foots again. But unfortunately, with late presentation, this has to happen. And you can see the different roles that endovascular treatment is playing, from screening, with the management, with stents, with bypass. And ultimately, the goal is to save the patient life, but not just quantity, but also quality. So like Dr. Dafe mentioned, if you can save the knee joints, it changes the quality dramatically. Sometimes you have it as high as the iliac. If you want to start application, what do? There was one case we went in, it was at the iliac, just the one he showed. At the iliac, where do you start amputating from? So that makes a significant difference. Now, this is the one reason why this long-term treatment that is happening here must happen in the country, and why cardiac care is spearheading this and spearheading education, is that when you have acute limb ischemia, it doesn't matter how much money you have, you cannot reach abroad with an acute limb ischemia. No plane will carry you. The increased pressure in the plane and the oxygen cannot help you. So it's quite important that local capacity is developed first to identify it, to educate the patient, like Prof has rightly put out, and then to offer treatment when it has crossed those lines across this. And it's quite important that some of this therapy and endovascular therapy goals are reached, which is to reduce deaths, to prevent limb loss, to relieve symptoms, to improve function and quality of life, and as much as possible to leave nothing behind. Okay, so we try our best amongst all of this, and everybody has a role to play. We must try and look at what can happen over the next 10 years. And you can see in the pictures, you can see baseline, you can see intervention, and you can see the final result. That final result of blood supply can be dramatic. You know, the patients will pray and pray for you, and this is possible through some of these devices and endovascular therapy options that are available. So the implants that is now put inside the blood vessel, a lot of people ask, so what will happen? Will it stay there for life? Well, yes, it will stay there for life, and it's drug-eluting. We can use balloons in the peripheral vessels because they are bigger, unlike the coronary vessels where the risk stenosis is very high. So in these cases, you can use that, and sometimes, a lot of times, the balloons are either drug-eluting, cutting balloons, or other types that are used. Okay, so I'm just trying to run a commentary on the slides in the absence. So maximize the gain, minimize dissection. Remember that dissection is also a possibility. In these endovascular treatments, a lot of complications could happen, and we must be ready for the complications. One of the things we've also noticed is because a lot of patients have also cardiac disease, we must be ready to also give them cardiac assessment and even stents while in the same cath lab going after the leg. And so maximize the gain and minimize the risk of dissecting that artery. The worst case you can have is to call a surgeon in to come and open that leg because the artery has burst in the leg. You will be in serious trouble. Remember that the femoral the thigh can take almost 5 liters of blood without you even knowing much. So it's quite important, and these are things we must do to preserve the long-term care of patients. Okay, and so these are all the options that are available: stents, balloons, different catheters for diagnosis, and this is a brief summary of some of the gadgets that we have to use here. Of course, if you look at the goals, then you know that the benefit outweighs the costs. And of course, we always have to look at the cost-benefit ratio. In this case, the cost-benefit ratio is quite high, and it's quite important for all of us to know what is available here in the country and to play our role in diagnosing, in educating, and in offering appropriate service as at when due. Okay. Mohammed, I think I've been able to do a lot of justice to this. Is there any other thing?
Yes. So I'll just put it forward. So this slide is just showing the options available for vessel preparation, treatment, and what you have for the bailout. And also, it also shows what you have for chronic total occlusion for the short and long lesions.
Okay. So Mohammed, are you done? So you will get the slides in the mail. You will get the slides in your email, all of these slides. We'll have the Medtronic slides, the one that we missed out here. And you can see that they've done a lot of trials across the world. They've not done in Nigeria yet. And we are hopeful that we will be on the centers when we talk. Done a lot of criteria, 64 global sites for 1,500 patients. So you get all the slides in your mail shortly after. Then allow for Tuesday, before Tuesday, to get all the slides. You also get a link to YouTube videos to watch. But if you go to YouTube, check for cardio care, and you will see how to use pacemakers, how pacemakers are used, how to identify kidney injury early, outpatient management of diabetes, chest pain management, myocardial infarction, hypertension, your approach to a patient with breathlessness, how to manage patient with COVID in pregnancy, a lot of others. So it's a very rich channel. I want to indulge you to also spread out, share with friends and other colleagues who could also benefit from this. Mohammed,
yes, can you hear me?
Yes. So your final comments, we're out of time. Mohammed, your final comments.
Can you hear me? I can hear you now. Can you hear me?
Yes, we can hear you.
Okay. So thank you. So it seems like the audio wasn't audible enough. So in summary, what we're just trying to show here is the offerings we have for the peripheral artery disease for the limbs in order to save the limbs. So aside from this, we also provide some sort of trainings to also improve the number of skilled professionals within. Thank you so much, Dr. Iseko. Can you hear me?
Thank you very much. So we are rounding up now, and we have taken a lot of the questions. I can see a lot of very senior professors that are here. We are very grateful for joining, for you joining up. I can see, I saw Professor Nigeria, I saw some other very senior professors and doctors in the profession. We are very grateful to have you. Your presence encourages us, and I hope it was value for your time. If you look in your chat box, you will see where to get your past webinars, cardiocare.ng/webinar-replay. So if you click on that link, you will see a lot of the webinars that you can go and you can improve your practice beyond diabetic foods. Some of the books that Prof also mentioned that she has authored for patient education and healthcare provider education, we'll find a way of getting that across to you or give the links on how to reach that. We want to thank everyone for joining us. We want to thank Medtronic especially for supporting us. We want to thank Prof for chairing this event. Prof, thank you very much.
Thank you, Prof. Thank you.
Yeah, so the last time I think I was a house officer in my unit. I don't know if I was extended in that house job. But thank you so much, Prof, for having us. And you could see the professorial.
Yes.
This is why I said that they are
professional touch.
Yes, like you said, they are the custodians of the profession.
Exactly.
We are very happy to have you. Dr. Dafe, Dr. Ofisoyi, and the rest of the cardio care team. We are very happy to be here. I can see Dr. Folashade Taiwo. Thank you very much, Ma, for joining us. I can see Dr. Ifeoma Moye. I think he's coming from the US. And Dr. Ngowula, I think he's joining us from Caribbean or Canada. Yes. So quite a number of people. Thank you so much for joining us. I'm sure that's value for your time. You also get in your mail the MDCN accredited 2 CME points for attending. I think you now get it to 2.5 because it's 230 for attending this webinar. And if you don't take anything, take back that history, examination, and education. Take those three back. Make the diagnosis early, refer early, get specialist input. And remember, it's a multidisciplinary team care and approach. So we don't want to Prof, any final comments, ma'am?
Well, I want to thank all the participants, particularly those who waited, till the end. That's quite commendable, and I'm sure they have had value for the time that they stayed with us. I also want to thank Cardio Care for the continuous medical education that they are doing to empower healthcare providers to do what is right for our patients, to make positive impact in our patients, because our patients look up to us, so much, sometimes almost like looking up to God actually. And when we don't do what is right, we disappoint them. So I think this is one of the ways we can empower ourselves to do what is right and timely, for the day. I want to take this opportunity to emphasize timely referral. Many times, for example, when patients are sent to the teaching hospital, I can tell you that 50% of the time, the only option we have is amputation because they are not sent early. So timely referral is so important, it's so critical for the survival of these patients. So, and I want us to keep that in mind always. So I want to thank everybody, Dr. Iseko, Dr. Odafe, Dr. Okusui. It's been a wonderful time. So, and the others, I mean, sorry, I don't know your names, but it's been a good time. So God bless you all.
Thank you very much. So thank you, Cardio Care. And Cardio Care is aiming to be best medical tourism. So most of these people that have to be rushed abroad for this kind of things, we can do a lot of the procedures here. We are less than 90 minutes away from any city that has an airport. So somehow we can at least be able to give. Are the procedures cheap? Not necessarily. But nothing good comes cheap. And you can see the extended amount of technology and expertise that has to go into this. So that is why prevention and early treatment and early referral, it makes a whole lot of difference, which is why we are here. We want you to treat the patient better, to understand it better, to start the therapies early, so that only fewer patients need to have this extensive treatment. So thank you so much for joining us. Our next webinar will be the full annual cardiovascular symposium first week of December. Wow. You should look forward to that. That will be fantastic. 2 to 3 days of fire stuff. From ECG interpretation, hypertension, diabetes in OPD settings, approach to kidney disease, approach to lipids. If you can read, you can read an ECG. If you attend that seminar, you will read an ECG, whether you like it or not. Basic life supports, and elements of advanced cardiac life support. So we want patients to live. And Abuja Cardiovascular Symposium will be in its 5th edition. Every year it has been bigger and bigger. Last year we had to do it completely virtual. We still had over 300 participants. Previous years we had over 190 participants from 19 states of the federation, physical. This year we're going to have that. As always, there is a minor charge that goes with Abuja Cardiovascular Symposium. Not for running the program, but to make sure that you sit down and you listen through and through because your money is at stake. So those are the things that. So we look forward to having you at the Abuja Cardiovascular Symposium. You'll be getting emails to remind you and to tell you when it's coming up. And we'll also send to your hospitals as well. Thank you so much for joining us. Till we see you again, have a lovely weekend.
Okay. Very much.
Thank you.